What do you treat with it? So obviously you begin with an empirical therapy. You do not wait for your antibiogram after 48 to 72 hours because that can be devastating. So you always target the organism, as we discussed, either it is cons or MRSA, very rarely GNV, and fungus, especially in your immunosuppressed patients. So begin with your MRSA coverage, vancomycin or ticoplanin as a first line agents. Linezolid and daptomycin are kept as a reserve drugs, as a VRE drugs. Coverage of gram-positive and gram-negative has to happen empirically, and once you get your culture, you are sure it is a gram-positive, you can come down on your gram-negative. If you think it's a gram-negative, go ahead with the third generation cephalosporins with beta-lactamases or carbapenems. And for a fungal sepsis, the better advocated are your echinocandins. Duration, as we discussed, minimum 2 weeks of antibiotics, that is for an uncomplicated, and if it is complicated with your infective endocarditis, then it is going to be as per your IE protocol of 4 to 6 weeks. For a GNV, it is minimum 7 days of gram-negative CRBSI, and for a cons, it's as we discussed, it's a little lenient. With or without your catheter in situ, your appropriate systemic antibiotic should be for 5 to 7 days. For your MRSA, it has to be minimum for 14 days, and if you think it's an IE, 4 to 6 weeks. For GNV, it is 7 days, and for fungus, as we discussed, at least 14 days after the previous or the last negative blood culture. How do you prevent CRBSI? So, preventing CRBSI is very important, and it is partly the role of a doctor and partly the role of the staff who is taking care of the patient. So, the most important is education, training, and having an adequate staffing and teaching them about aseptic precautions and the importance of hand hygiene. So, these are the most important precautions. Even if you end up placing your catheter in the most sterile and aseptic precautions, without a proper hand hygiene of the doctor as well as a staff nurse and improper education and training of the staff can always result in an MRSA growing in your line and ending up in a line infections. And whenever you try to place a line, full body drape for the patient as well as for you, starting from your cap, mask, gown and gloves. As far as possible, avoid femoral lines, prefer subclavian vein sites under ultrasonic guidance. Try to have a CVC with minimal number of ports so that you do not expose the patient, and if you think you have placed that line in a very emergent situation, try to remove it within 48 hours. Skin preparation has to be done with 0.5% chlorhexidine or at least tincture of iodine or iodophore. If in spite of all these aseptic precautions, if your CRBSI rate is not decreasing, you can think of some antibiotic lock therapy, especially if the patient is with a catheter for more than 5 days. There is no role of giving a prophylactic antimicrobials for the CRBSI. Yeah, in some long-term catheter patients, you can think of having a prophylactic antimicrobial lock solution, especially in patients with multiple history of CRBSI infections or for a long-term catheter. You can always have a 2% chlorhexidine wash, daily skin cleansing of especially your catheter locks where the injection site is there, and especially that is the hub, and replacing of the tubing, especially if you are administering blood or blood products, replace the entire tubing and the blood products frequently or at least once in 48 hours.